we had enough data on the non-invasive tests, family history, blood pressure, HDL cholesterol ratio, smoking status, binary plus or minus fluoroscopy, and age, to be able to return people to flying without angiography or to identify them as being too high risk to continue flying. NASA would send folks over to us in San Antonio for the same evaluations as we had been one organization, and then up until a couple of years ago, they now have their entirely independent program. And then much of the FAA's policy was derived from the School of Aerospace Medicine policy, and in fact, on a quarterly basis, even up through the years that I was on staff, we would meet and compare our data and compare our methodologies and keep track of our occupational management groups together. We started at times offering it to special forces and other high-risk occupations, and then I think in a minute I'll talk about how it went out to high-ranking individuals. But now I want to just take a second to tell, from my perspective, what happened with coronary calcium, why we're at a time where it's so controversial. Part of the problem is based on the success that we had, my mentors say they saw it being used in a commercial manner because it's such a neat story. It fits on the cover of a popular magazine. Patients can identify with it, but of course we didn't necessarily have the data on what to do with it. Dr. Sidney's already explained the calcium. I'll skip that slide today. But I think what happened is we had a over-promise early on with commercial or financial profiteering where it perhaps went out into the marketplace too soon. And we would get calls at the consult service when I was staff from people who had this saying, well, they said you guys did it for pilots. What am I supposed to do with my score, right? And we would have to very politely explain that we were using it for a different purpose, which was the safety of flight. Although all of us on staff had followed the early thinkers who had started noting this, their opinion at the time was that this meant you got secondary prevention. But they were using the data with a fluoroscopy positive, which was roughly a score of 100. So in their minds, a positive calcium score was secondary prevention, but they had the benefit of not having to know about the calcium scores. So anyways, we went out into the marketplace and created skepticism, even resentment. For the purposes of long-term trials and things like this, a calcium score adds an additional cost and an inconvenience. It's much easier to use things that are already in the medical record. And then, of course, there's been the radiation and incidental findings. So I hope that I've convinced you of the strength of calcium scoring when you're using it for the purpose of safety of flight. In a second, I'll tell you some of the numbers that we achieved. It is now a key tool that is used by most of the air forces of the world, the FAA and NASA. And I can't emphasize enough that the outcomes are not about the score at all, right? It's about what you do with the score. And that becomes the important thing. So tying into that, the senior military leaders at Walter Reed saw what had happened with the pilots, and to an extent the Army was doing a similar program. And so they decided to start offering this to VIPs, high-ranking individuals, people that had just made general, and retirees. And they offered calcium scores to around 16,000 people. Dr. Belines, the chief of cardiology at Walter Reed, was part of publishing this registry last year. Retrospective, the individuals were given their scores, and in most cases they were told that you should talk to your doctor about secondary prevention because we believe this represents some marker of disease. There was, to my knowledge, there was not any official statement that they were given other than they were given their scores, and they were told that this had been used by places like us and that it was a screening tool. And so at Hattie's request, I have two graphs here to show that if you had a score and you got statins, in this retrospective analysis, you benefited, and if your score was up or closer to 100, the numbers needed to treat were very low. I think it was 8 or it might have been 12. But in any case, this is certainly a uncoordinated, but certainly a project that came out of the success that we had had with the pilots, where other military members decided to offer it in the Washington, D.C. area.
Could you go back?
Yeah. Oh, sure.
just for those who haven't seen these slides before, I think it's pretty striking that, well, the top left is a score of 0.
Correct. Yeah.
And then top right is 0 to 100 or 1 to 100.
1 to 100. Yeah.
So in the people 1 to 100, I think what the blue is no statin, the red is statin.
Yeah.
There's very little difference in outcome. But in the bottom left, that's a score of 100 to 400, and there's a striking difference. And then the one on the right is greater than 400. So that goes along perfectly with the new guidelines that recommend statins for people with a calcium score greater than 100.
Yeah. What's also interesting is the patients with a score of 100 to 400, if treated, their risk approximates patients with the risk of less than 100 not on statin, which is quite encouraging. If we adopt the new guideline.
Look how much it's dropping the rate of events out in 12 years for those with a score of 400 plus.
Yeah, one caveat that is interesting to me as I think about these patients is that we are somehow telling the public or our physicians that we must screen the intermediate group, which makes sense statistically and to treat these people. However, the people at higher risk have the highest risk factors, and they're going to have the highest risk scores. And the efficacy of our intervention depends on the people taking their medication. And a lot of these people drop their medications, drop their efforts at a year, if not most of them by year 5. So in my mind, I wrestle with this and I say, okay, you're high risk, I'm going to give you a calcium score anyway. Here it is. It's super high. Well, we knew. But it's that. I don't know. I wanted just to bring it up.
So the 2 points here are perfect, right? The 0 score doesn't need to be treated, and the high score might be additionally motivated if they get their calcium score, right? So thank you for making those two points.
Joe, these patients had an ASCB score of 0 or low, right?
They weren't calculated.
Okay.
They were retiring. They just made general. They were offered a calcium score.
About how old were they?
The average age was 43.
43.
Yeah, the average age was 43.
Incidence of hypertension, in other words.
Off the top of my head, I don't remember, but the active duty military is pretty healthy, so we generally are at the little bit better than the general population at that time. Now we're approaching. So I'm optimistic that the coronary calcium score is being given a second chance, having seen the success that we had in the aviation community, albeit for a different purpose. Although any of the pilots that were disqualified or identified with calcium score did receive secondary prevention. Maybe someday we'll be able to go back and publish that data. So far, we don't have the resources to do that. I think that I'm optimistic that the new guidelines are giving coronary calcium a second chance, if even for the intermediate group, as Dr. Sidney's slide very well showed. So, one of the more interesting facts about the School of Aerospace Medicine is probably the most influential thing to come out of the space program was Dr. Cooper's work. And he was the chief of the aerobics lab, where everyone had their stress test. And his observations that the individuals that had better VO2 maxes did better for more years at being able to remain on flying duties, obviously has changed the world. And he continues to do this at age 88 at the Cooper Institute. And he was a direct result of being able to work as part of the School of Aerospace Medicine for the space program. Anyone who would like to read more about this, the current cardiologist at the School of Aerospace Medicine is Dr. Davenport. He's been part of a recent group of air forces, friendly air forces, that have published the collective data of screening and detecting plaque before the accident for the purpose of coronary vascular screening in high risk occupations, low risk by traditional calculators. And then Dr. Budoff is part of NASA's independent, now they've made their own regression equation using their data to form the AstroCharm calculator. And while ours was never released to the public, we felt that it was too restricted to what we were using it for. This one is available as an app and is available at a website. You can certainly calculate your score. So just how successful were we? We certainly beat the 1%. Some of the data shows that with Air Force pilots, we are at a 0.15%. The commercial airline industry, the last fatal cardiac event was 1 year after that call in 1971. That was 1972. 118 people died in a mishap where one of the pilots had a heart attack. Since then, there have been 6 fatal MIs in flight, but the calculations from the 1% rule have been effective. There's always been a co-pilot to be able to take over, sometimes even another pilot in the passengers. And so when I was active duty, we used to joke that our guys were healthy enough that when they were flying on vacation, they sometimes would back up the FAA medical standards. So now, the true test that we used to have as young flight surgeons was whenever we had to convince pilots they couldn't fly anymore, our job was to convince them they wanted to grow to be grumpy old fighter pilots or grumpy old pilots. And these 2 gentlemen are still alive, and I would propose to you that the work that Dr. Cooper did with promoting aerobic exercise is something that anyone who's trained in the military continues for most of their life, and that the standards that we used were effective. And in the case of Dr. Anderson, or in Bud Anderson's case, he was actually the chief of all research at Edwards Air Force Base, and so the argument that we were doing what the pilots wanted doesn't hold up, because they were the ones driving the safety numbers that we achieved, and they wanted us to do what was safe and what was the right thing to do. And I think the story of this coronary calcium is a great story of how 2 vastly different types of sciences were forced together by chance, and the end result was to develop safety without using the blinded prospective trials that we're so used to. Thank you for your time.
We have time for questions for both of our speakers.
So thank you, Dr. Stein and Dr. Sidney, for bringing to my awareness the efficacy of CAC scoring. So as an endocrinologist that was trained at the University of Washington, where lipids is premier there, actually never got training in CAC, did not order calcium scoring in my patients. So really kind of come from a clinician standpoint where we were taught to really focus on the LDL and family history in terms of figuring out when to treat with a statin in our non-diabetic patients. So as you can imagine, as an endocrinologist, obviously my diabetic patients, I don't need to have additional testing to know when to put statins on those folks. For the non-diabetes patients, I do, this is obviously an important tool. And so the questions I have is, one, is really kind of implementation-wise, sort of practically speaking, how do you order it, insurances that are covering costs of the patient, and how do we even counsel the patients? Because any test that you do for somebody who's low risk, intermediate risk, I mean, we deal with the population now where folks are, they're Googling things, they're reading things on the internet. They want to know a lot of these risk benefits. And then from a practitioner standpoint that maybe didn't get formal fellowship training in this, what should we be looking for in terms of false negatives? There was a mention in one of your slides about artifacts or some of these things. I mean, this is just like really kind of practical stuff in terms of optimizing the use of this technology and helping our patients.
Yeah, I'll end. So incidental findings. I mean, everyone hears some of the horror stories of. I think at our Sacramento meeting we had someone bring up that there was an incidental finding and led to a biopsy that led to a death as a complication of the biopsy. Sure. The vast majority of incidental findings, like the story in the San Jose Mercury News of the lady that had a coronary calcium and discovered lung cancer. She was a non-smoker. I have not experienced that. I don't know. I've not had too many people upset about the minor inconvenience of an incidental finding, or a finding that turns out to not be so incidental, and they're happy to have discovered it inadvertently.
If you're ordering these scans, or what are you guys doing practically?
Yeah, so
I'm going to share the practical.
Go ahead.
Go ahead. So for me, it's a very, very good tool, and mainly because the way that we're thinking now of cardiovascular disease is much more molecular, and of course it all boils down to risk factors that are at many levels. So you have the lipoproteins, you have the inflammatory cascade, you have the capacity of the blood vessel to get rid of the cholesterol, called efflux capacity, right? That it has multiple levels of complexity, right? So we have an enormous amount of risk factors, the soup, right? It boils down to this very simple test that you can do in 10 minutes, and it'll sort of give you a summary, and then from there you can, go ahead and look for your risk factors, or when you know that somebody has a family history or has high LPA. So for me, when somebody comes into my office and says, my mom died at age 40, my LDL is 90, my HDL is 60, and I just pat him on the back and say, you're fine. I don't have the ethical capacity or the knowledge to tell them you're fine. Right?
Right.
So
I think like the data is clear that CAC is useful, right? Because the CAC data, like you get a CAC score of 100, LDL 85, you're going to put them on a statin, right? So it's like kind of answering that extra factor of like somebody who you otherwise would exactly maybe say Framingham risk score is too low, no family history, LDL is 70, you're good. But my question is, practically speaking, how do you order the test? Is the insurance covering it? What's the cost of the patient? Sort of these more practical, because the reality of this technology is, as like an endocrinology fellow who, sees folks who are in these high risk stratospheres. I mean, the reality is that I think the younger doctors have not received training in this technology. So
Dr.
I can just tell you just one place example from here at Stanford. We negotiated a price with our radiologist, which for Stanford is really cheap. It's $150. That's more than a lot of places would be. I think average price, though, is probably somewhere between $75 and $200. The radiation exposure is 1 millisievert on average. The insurance, some insurers will pay, but basically all the patients just pay out of pocket, and our radiologists don't try to claim, they don't try to get coverage from the insurance companies. And let's see, we get a report. Every place reports a little differently, but we have it reported using the MESA coronary. I can't remember what the name of the website is, but MESA coronary calcium. If you just put that in, you'll get age and sex percentile where the patient fits in, and you can counsel the patient. For your age, you're in the whatever percentile, and then if the score is 0, just what we're doing, and whether or not it's right or not, I don't know. is we're recommending a return in 5 years to see.
Kind of like bone density for osteoporosis.
If there is a high score, we rarely order a repeat, because I don't think there's any point.
Yeah.
But there's a lot of controversy about serial scanning and rate of progression and what does it mean. And there are, I'm sure, a variety of opinions among the experts in the room.
And the other
I mean, that's like, so helpful, because I don't normally, do you get any training on CAC?
No, I'm getting it right here, which is applies to the patient
And I don't even
to our
know.
radiology.
Yeah, exactly.
The other thing that was helpful for a patient I had that was out of town that I couldn't send to Stanford, which is really easy because the Stanford report is just like your CAC score is 0.
Oh,
your
wow.
CAC score is this. Is that actually we had Victoria Dupuy here from No More Broken Hearts, and on her website she actually has like all the places in California, or many places in California listed that does the CAC score and like what the price is, and they're all around the Bay Area, so that might be just a practical resource.
And if I could just say a couple more things, just that I think would be of practical value. I virtually never order any test in an asymptomatic person after getting a score back. I know there's a lot of concern that, oh, you're going to order a stress test or order a cath or something like that. I made an exception very recently in a patient who had a score of 3,600 and had in his left main a score of 130, and a 60-year-old man who is getting ready to go on a 21-day hike out in the wilderness. And so I decided to order a stress test in that person. But generally, that's not what you would do.
Right, thank you.
I would say, one thing I want to say is Kaiser does not have any system-wide guidelines on coronary calcification.
Interesting. Are they doing it at Kaiser?
Oh yeah, I mean they're available, I think, probably at pretty much all of the sites.
Is there any roadblocks for a primary care doctor to order one?
I couldn't answer that one. Actually, I don't know whether they can just go ahead and order them.
I mean, unfortunately, our university has not gone on with the idea that this is a really helpful tool. And so we can't get one for a reasonable price, which is why we send them to somebody else. And that's a sort of absurd comment, but that's I sent help if you go down here.
Kaplan.
So this is a question for Dr. Sidney that Dr. Sky also, there is a controversy, and so that there are differences of opinion. And we had a whole session here on this about the U.S. Preventive Services Task Force gave it an I, insufficient evidence, and it was interesting in your presentation. So the question is, what does it really mean to have a high CAC score? So one argument is that, well, as you were pointing out, it's proxy for all these other risk factors. And so that it tells you maybe there's a constellation of all these other risk factors that are there. But, if it's, the advice is, well, you shouldn't smoke and you should exercise more and you should eat less and so forth. That's actually true for everybody, you see, right? It isn't really specific. And I think that what a lot of people think is, oh, well, you can see this calcium, so that's sort of the message is you need to revascularize the coronary arteries. But we've had, the Courage trial, and David Marin talks about the Orbita trial and others that show that really that doesn't work. And I'm not entirely persuaded that there is clear evidence that statins make a difference. And
You don't believe that graph?
well, it's because there's self-selection, and so, if you go back, and Ralph Horowitz used to be the chair of medicine here, and Alan Feinstein have this famous paper where if you look at people who self-select into treatment always do better. And so non-randomized studies that people who make the decision to take drugs always have better outcomes. So absent a randomized clinical trial, it's just very hard to make that determination. And so that's the bottom line, really, that I do think we need a randomized clinical trial. I mean, there's a lot of suggestion that it's going to be.
Yeah, I would agree with that. That's what I was saying. You can't really, you can start to piece it together, like in that Phil Greenland article, but we don't have the evidence. And, I don't treat But if somebody had a high coronary calcification score, I probably put them on the staff.
Are there plans from RCT?
NHLBI is convening a workshop chaired by Phil Greenland this summer. You're aware of this?
No, it wasn't actually.
Yeah, and the purpose is for NHLBI, National Heart, Lung, and Blood, is to examine whether now is the time to invest in a primary prevention trial. So they're thinking about it.
Big and expensive, yeah.
But,
Yeah,
and
a long endpoint, and long term.
in the task force, I mean, it's important to emphasize that this insufficient evidence doesn't mean that there's no evidence. I think they were pretty, first of all, I think the evidence is very persuasive that having a high coronary calcium score is an important risk factor. That it predicts events and does it really well.
And the insufficient evidence was for the general all population, and this is identifying a different population. So I feel like it just doesn't apply.
Yes, and we talked about that a little bit. So they're talking about asymptomatic people in primary care.
As opposed to medium, asymptomatic medium risk or intermediate risk.
Calcium is not a risk factor for coronary artery disease. It is coronary artery disease. It is coronary. It's the tip of the iceberg. It's showing soft plaque. It's there. You've got it. It's like being a little bit pregnant. It's like a touch of cancer. You have the disease process. You may not see it yet the zero score. You may eventually develop it, but it is. If it's progressing, you'll see it progress. And that's the misnomer, I think, of saying it's a risk factor. It is the disease. It's a marker for the disease.
I think
It's like saying having a high CA is a risk factor for colon cancer or something. It's not a risk factor.
Your point about whether or not the calcium score should be, a positive calcium score should be viewed as a secondary prevention patient. Because you know the recent look at aspirin, primary prevention aspirin, has come down, basically said, oh, well, the beneficial effects of statins in this primary prevention group completely overwhelms the benefit of primary prevention aspirin. But should in fact there be a little asterisk by that says the primary prevention statin patient who's got a coronary calcium score of X, actually they probably benefit from the added aspirin, yes or no? And does anybody know, does that data exist anywhere?
Well, I made that comment because in preparation for this talk, I called the former chief of the School of Aerospace Medicine, and he was one of the individuals that was one of the first to do these coronary calcium scores. They had the benefit of not knowing at the time, but they were really looking at scores that were 100 or more. And so based on their analysis, they were seeing data that made them convinced this was equivalent to disease. So that's where the concept in their minds came up that we're doing this as, once we identify a positive calcium score, because they had just the binary, it was secondary prevention. I don't think that that's all looking back at it retrospective and saying that. And then I think, Dr. Kaplan, I would just make one tiny point. The individuals in the military that were retiring or promoted to general, yes, it was voluntary. Of course, they said, yes, I'll get the calcium score. But there was enough general knowledge at that time of the success of using calcium scores. Granted, there was this inappropriate belief that the calcium scores had made the pilots safer. It really made flight safer, and indirectly the goal was making the pilot's health safer. But at the time, that data wasn't there, so there was this attribution that may not have been correct. But interestingly enough, the primary care providers and those that saw most of these patients that were in the study from Dr. Valines, anecdotally, I can tell you when they saw their primary care doctors, they were told, I was told I have this calcium score, it means I need to be treated because it's like I have heart disease. That was not a trial. It wasn't. I can't go back and find that data for you or show you that, but because it was a registry. But that was the thinking at the time. It wasn't, But I know that doesn't change the fundamental fact.
No, but I think Jim's comment's very important because it's saying it isn't a primary prevention trial. It's a secondary prevention trial because the calcium score means that they do have coronary
But it doesn't eliminate the selection bias. I just wanted to mitigate it a tiny bit.
And I just wanted to mention too, there is, while it's not